Exactly. Hello, Miss Lily. Is the Lily cam on?
Lily cam is on.
Okay.
Lily cam is, yeah. I see the lights flashing.
This season on The Golden Bachelor.
Happy Friday, Baylor College of Medicine and friends of Baylor. Well, I'm officially exhausted trying to keep up with Washington, D.C. But I'm going to try and help everyone stay abreast of all the news. First of all, what's new in autism spectrum disorders, ASD? Leucovorin has now been recommended for treatment of kids with ASD. Why is that? So leucovorin is actually folinic acid, and it's often administered with chemotherapy because chemotherapy sometimes inhibits folate metabolism. The initial interest in leucovorin stemmed from the fact that some autism symptoms resemble cerebral folate deficiency, and that's a condition where folate's not utilized very well in the brain. And then in those cases, leucovorin may be beneficial. So what really is needed now is a randomized double-blind trial to see if it actually works on other autism diagnoses. You don't, FDA doesn't usually just say it's recommended because there's an association, and so I don't quite understand it. A trial needs to be done to actually show if it's useful in other forms of autism. So, but there you go. Also, trying to keep up with Washington, D.C., the FDA issued a physician notice to begin the process of changing the safety level for Tylenol. And the thought was that there's a couple of cohort studies that have showed a potential association between acetaminophen use during pregnancy and adverse neurodevelopment. Now, last week we went over clinical trials. Cohort studies cannot prove a cause and effect. These are like the old studies that showed caffeine might be associated with pancreatic cancer. It didn't turn out to be causal or anything like that. So this is one of those things, again, where the FDA should be assessing large data sets. There have been a number of cohort analyses that have shown no benefit. And by the way, febrile illnesses during pregnancy also cause neurodevelopment changes. So again, this is not particularly understandable to me, but there it is. Then, of course, the Advisory Committee on Immunization met last week and unanimously voted to replace what was universal COVID recommendations, in other words, everyone can get them, with something called shared clinical decision-making. And what that means is that you need to consult with a physician, nurse, or pharmacist, and if that consultation leads to a recommendation that you get a vaccine, then you can, if you're under the age of 65. I don't even have a clue what that means. Now, what they did say, and thank goodness, they voted not to require a prescription, but it was a very close, it was 6-6 vote, and the chairman of the committee was the deciding vote. So I don't get this at all, because actually, the reason it's called public health is it's for the public. It's not called individual health, and these recommendations are supposed to be for the public. If now every person has to get a consultation with the healthcare provider, I don't even know how you do that. So like imagine a working couple with kids. Who do you approach and how do you get that? That'd be like saying if I want to get on the bus, I need to consult a transportation expert. I don't know how that's going to work. I think what it'll do is limit the number of people who get COVID vaccines who are under the age of 65. I still recommend everybody get a COVID vaccine because there's a lot of complications in young kids under the age of 2 and everybody. So I would just recommend you get one. Now, I think the most telling thing is what are the health insurance companies saying? The health insurance companies are saying they'll pay for every COVID vaccine no matter what, and up to until the end of 2026. Why would the insurers agree to pay for anything no matter what, even no matter what the recommendations come from the vaccine committee? The reason is they know that it's worse to get sick with COVID. It costs them more money than it is to get a vaccine. So I think the insurance companies are telling you, offering it free of charge for everyone, that you should get a COVID vaccine. So the newest one is called Spike. It's called Next Spike, and I want to show you We've talked about this a lot. This is the relatedness tree of all of the variants. And the most recent variant is this XFG dominant one. I'll show you that later. Last year was LP8.1, and actually the recommendation at that time was that maybe that LP8.1 should be the target. In fact, the target is JN1. JN1 was the target in 2023 for Novavax, and Pfizer and Moderna targeted this XBB. They've changed it to target JN1, and the next spike is not just the entire spike protein, but just a component of it. So the spike proteins stick all over the virus. This is a study from UT Austin that showed that antibodies are generated to multiple sites of the spike protein, but NextVax just focuses on the N-terminus, the receptor binding domain. So a small part of that of the spike protein that fuses with human cells. And it apparently generates a much better immune response and a more specific immune response and better protection. So I think that's an advance. It's apparently lower dose too. And I think the fact that it's not directed to XFG is fine because JN1's in the same lineage. I mean, XFG came from a recombination of JN1 and XDV. So I think that's a good target and should be very effective. So go get your next generation booster as soon as you can. Other key changes from Washington: the hepatitis B vaccine is under review. The biggest concern and why when children and newborns are given the vaccine for hepatitis B is that if women are infected, they can transmit perinatally to the child, and so we usually give vaccines right away to the child. What they've changed is say women should be screened for hepatitis B, and they want to postpone or delay it for newborns. So I don't know. They tabled that. They haven't made a decision. They're still trying to figure out what to do. I think it's dangerous not to give the vaccine because it means there'll be more hepatitis B infections in young kids, which is really, really bad. And then this is one that they came up with. They wanted the MMR vaccine. It has another one. It's MMRV that includes varicella or chickenpox. There was some association of higher febrile seizures with the MMRV vaccine, and so they're recommending MMR and the V vaccine be given separately because there was a slightly lower incidence of seizures. But I'm fine with that. Just means the kids will get 2 vaccines instead of 1. Kids won't like it, but if it reduces febrile seizures, that's fine. Okay, then I got another question. Very busy week. What's the typhus situation? Well, typhoid fever. I love typhoid fever. So typhus is in Texas. It's actually pretty commonplace. So a woman said, I heard on the radio that a woman in San Antonio was pulling weeds in her backyard and got typhus. And she advised everyone to wear an N95 mask. So that makes no sense, but let's explain why. So there's a lot of typhus in Texas. There's 6,700 cases. It's a flea-borne illness. We've had 6,700 cases in the last 14 years. Almost 70% of the cases were hospitalized. There were 14 fatalities. So it can be a really bad disease, and this is what it's been going on in Texas. So really high this year, not quite as much, but still a lot of typhus. So murine typhus is caused by Rickettsia typhi. It's a bacterial infection that you get through being exposed to infected fleas. The fleas actually, usually the cycle is in rodents, it go to fleas and fleas back to rodents, but if you're exposed to them, you can get infected. And the other animals that are often infected are possum and, of course, feral cats, which is why, Lily, one should be particularly, stay away from cats. And cat fleas and rat fleas are the most common vectors. The incubation period is about 7 to 14 days, 1 to 2 weeks. And people present with almost like a flu-like illness. It's fever, headache, chills, sometimes with rash. And the reason it's important, it is treated with the doxycycline, and so it's important for doctors to be able to recognize. So sometimes people show up with a flu-like illness, and if it's flu negative, they ought to be thinking, is there exposure to, for fleas, particularly in southern Texas. Well, even though the COVID recommendations are I think bad in that they say no one under the age of 65 needs to get it unless they have a high risk. sometimes it's better to be lucky than good because, amazingly enough, COVID's coming down. So it came up in July and August, and it looks like it's beginning to wane a bit. These are test positivity and emergency room visits, and even the severity indicators are coming down, so hospitalizations, but mortality is always late, so there are some deaths related to COVID. And also, if you look at the wastewater, it was really, really high, almost back to the same peak last year, but it's now dropping off. And the question is, why the drop-off? So, I don't really have a good explanation for it, but I think the reason is there hasn't been, if I can find there hasn't been a recombinant event. So, each of these mutations are like small changes, and the last recombinant event was when NB 1.8 was made back here in 2024. So it's incremental changes, and incremental changes mean that your immune system will still respond to anything that's closely related. In fact, the vaccine is a closely related antigen. So my guess is it's because the dominant strain remains XFG, 77%, and so we have a sort of broad immunity to that. When there is a recombinant event, and I guarantee you there will be one, then I think we'll see a big rise again. And same thing in the travelers data. It's flattened out, and the same thing, XFG remains the dominant one in Europe. The CDC plots endemic and pandemic likelihood based on the R number. We talked about a lot about this over the years. The R number reflects the infectivity of a virus. If the R number is greater than 1, you propagate infection. If it's less than 1, infection tends to go away. And the 1 means if I'm infected and one person is exposed to it, to go 1 to 1, that's R value of 1. If I infect 2 people, it's an R value of 2. And this was when it was rising in infection across the country, and now it's waning. So below 1 is the R number right now. So that sort of suggests that it's going to wane for a bit. And then they looked at by state. The dark green is it's declining. Only in the red or raspberry color there it's likely growing. So most of the country is seeing a decline. All right. Now my favorite story of the week was the IgNobel. IgNobel awards were awarded this year. And this is where scientists, really good scientists, get together and do something really goofy. Well, not goofy, but they do some really important experiment. And so this is one of my favorite things in the world. So this was a physicist, Fabrizio Almeida from Institute of Science and Technology of Austria, and his Italian colleagues from Max Planck Institute in Dresden and University of Padua and the University of Barcelona. They're the winners of the award. And what their big breakthrough was, they decoded the secret to a creamy cacio e pepe by showing that starch is the key ingredient to stabilize pecorino cheese. So this was published in Physics of Fluids, and the question was simply, what are the ingredients that are required to create the perfect cacio e pepe? And so the reason this is important is because if you put the pasta water in, it's too hot, everything congeals and you end up with like lumpy pasta. But if you put it on the right temperature, right low, and the exact amount of starch rate, it comes out as a beautiful creamy thing. So their solution, 2 to 3% of the cheese mass is given as starch. And when they did that, and it was under 65 degrees of centigrade, they got the perfect cacio e pepe. The recipe is published here. You'll see it. So anybody who wants to do it that. Okay. Want to end up with some shout-outs today. First of all, congratulations to Baylor College of Medicine alum Carl June, the University of Pennsylvania, who received the Borman Medical Innovation Award, along with Michael Sadelain of Columbia University for their research in CAR T-cell therapy. Carl June, of course, is a graduate of our program. Really transformational for immune therapy for cancer. And a shout out to Dr. Murugesan Palaniappan, Assistant Professor of Pathology and Immunology, sorry about butchering the name, who is one of the 14 recipients of the American Cancer Society's Discovery Boost Grant. This supports high reward exploratory cancer research, and his area of their research is on patients with advanced estrogen receptor positive breast cancer that had stopped responding to current therapy. So very important work. And finally, this week is Advanced Practice Provider Week. When we take the time to recognize our nurse practitioners, physician assistants, CRNAs, and others who are important members of the education, healthcare, and clinical research teams at Baylor and all our affiliated hospitals, physician extenders, advanced practice providers are absolutely important in the care of all of our patients. Anyway, lots of news this week. Have a great weekend, and I can't wait to see you next week.